Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're talking about varicose veins and chronic venous insufficiency, two common conditions that clinicians frequently encounter. We'll cover how they develop, how to recognize them, and how to manage them effectively. Let's get into it. Starting off with some basic pathophysiology, varicose veins are not just a cosmetic issue. They are actually a visible sign of underlying chronic venous insufficiency. In a healthy venous system, blood flows upward toward the heart, assisted by one-way valves inside the veins. These valves prevent blood from pooling in the legs. However, when the valves weaken or become incompetent, blood backflows and pools in the lower extremities, leading to venous hypertension. This chronic pressure stretches the veins, making them dilated and tortuous, what we recognize as varicose veins. Over time, this persistent venous hypertension can lead to progressive changes, including edema, skin discoloration, and even venous ulcers. Now, who is at risk? Varicose veins and chronic venous insufficiency are extremely common. Risk factors include prolonged standing or sitting, obesity, which worsens reflux by increasing pressure on the veins, pregnancy, advancing age due to veins weakening over time, family history, a prior DVT, which damages the valves leading to chronic venous insufficiency, smoking, lower extremity trauma, and females are also at increased risk. Now, as far as a clinical presentation, varicose veins are the dilated, tortuous, bluish veins often on the lower legs. They may be asymptomatic or cause aching, heaviness, and leg fatigue, especially after prolonged standing. The presentation of chronic venous insufficiency includes leg swelling, skin discoloration, which presents as brownish hyperpigmentation due to hemosiderin deposition, stasis dermatitis, which presents as itchy, inflamed skin, and venous ulcers, which are commonly found near the medial malleolus. A key clue to differentiate chronic venous insufficiency from other causes of leg swelling is that the swelling typically improves when the legs are elevated. Now, the diagnosis is primarily clinical, but a venous duplex ultrasound can be obtained to evaluate the degree of venous reflux and obstruction. The management for both venous insufficiency and varicose veins depends on severity and symptoms. First-line treatment is with conservative measures. This includes leg elevation, compression stockings, which are key to preventing progression, and exercise because calf muscle contraction helps pump blood back to the heart. And a few additional notes on management is that emollients and topical steroids may be needed in the case of stasis dermatitis. In the case of venous ulcers, a wound care referral may be necessary, and severe cases may need a vascular specialist. Now, preventing varicose veins and chronic venous insufficiency is all about improving venous blood return. You want to encourage daily movement, so advise patients to avoid prolonged sitting or standing. You want to recommend compression stockings to maintain a healthy weight and elevate the legs when possible. Here's our book med versus street med segment. Book med tells us that compression stockings and leg elevation are the first-line treatments for varicose veins and chronic venous insufficiency. However, in the real world, compliance comes into play. Many patients find compression stockings uncomfortable or forget to use them. Educating patients on why they're essential is key to improving adherence. And before we get to some practice, here are some key takeaways. Number 1, venous ulcers typically occur near the medial malleolus, whereas arterial ulcers tend to be on the toes and pressure points. Number 2, if a venous ulcer isn't healing, always check for infection or arterial insufficiency. And number 3, compression therapy is the cornerstone of venous disease management. All right, here are a couple of clinical questions. Question 1. A 55-year-old woman presents with bilateral leg swelling and aching, worse at the end of the day. She works as a cashier and stands for long hours. She reports brownish skin discoloration on her lower legs but denies pain at rest. On physical exam, dilated tortuous veins on the legs with hyperpigmented skin over the medial malleolus with 1+ pitting edema is noted. No ulcerations are seen. Which of the following is the most likely diagnosis? Is it A, peripheral artery disease, B, chronic venous insufficiency, C, deep venous thrombosis, or D, lymphedema? I'll give you a couple of seconds. If you chose B, chronic venous insufficiency, you are correct. The classic signs of chronic venous insufficiency include swelling, brownish skin changes, varicose veins, and aching that worsens with prolonged standing, all of which are present in this patient. Question 2. A 40-year-old man presents for evaluation of visible leg veins. He runs a construction business and stands for most of the day. He denies pain but is concerned about the appearance. Exam reveals dilated tortuous varicosities to the medial thigh. Hyperpigmentation is also noted to the bilateral lower third of his legs. No ulcerations are seen. Which of the following is the best first-line treatment? Is it A, sclerotherapy, B, compression stockings and leg elevation, C, surgical vein stripping, or D, topical steroids? If you chose B, compression stockings and leg elevation, you are correct. Conservative measures are first line for varicose veins, including compression therapy, leg elevation, and exercise. Procedures like vein stripping are reserved for severe or symptomatic cases. Great job! That wraps up today's episode on varicose veins and chronic venous insufficiency. As clinicians, recognizing these conditions early and initiating conservative management can prevent complications. If you found this episode helpful, be sure to subscribe so you never miss an episode. And as always, this is the Pro PA Podcast, where future pros in medicine are made. See you next time.